Excellent. So, welcome everyone. We're happy to have you all here today. My name is Emily Ann Opala. I'm the Knowledge and Research Lead here at the Center for Innovation in Campus Mental Health. Before we get started, I'd just like to do a brief land acknowledgement. So I'd like to acknowledge that I'm joining you all here today from Treaty 13 territory, which is the traditional lands of the Anishinaabe, the Haudenosaunee, the Huron-Wendat, and the Mississaugas of the Credit First Nation, which is also covered by the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share the land. When I do these land acknowledgements, I like to think often of a quote by Octavia Butler. And she said, "Belief initiates action or it does nothing." And so I hope that all of our beliefs in the importance of land acknowledgements and supporting our Indigenous brothers and sisters will lead us to action, will initiate that action. And that action could be, for example, going and looking at the Truth and Reconciliation Commission's 94 calls to action and maybe incorporating some of those in your day-to-day. So with that said, I'd love to move on now and get into the nitty-gritty. So just a little bit of housekeeping before we get started. Closed captioning is enabled at the bottoms of your screens. If you'd like to turn that off or on if you don't see it, you can click on the closed captioning button at the bottom of your screen. The chat function, also at the bottom of your screen, is for discussing thoughts and reactions to the presentation today. Meanwhile, we also have a Q&A function at the bottom of your screen. That's for submitting questions to our panelists, which we'll be doing at the end today. So we'll be doing about 10 to 15 minutes of questions at the end. Please, I'm going to ask you all to please fill out the survey at the end of the webinar. That's going to pop up on your screens once you close this webinar. Just to let you all know, the recording of this webinar will be available on our website sometime tomorrow. So with that said, I'm going to go ahead and introduce Leanne and Kaylee. Over to you, Leanne.
Hi, everyone. My name is Leanne. I'm a mental health clinician, a social worker by profession, and I work for the Canadian Mental Health Association in Waterloo, Wellington. So I'm based out of Guelph, and I work for a team called First Step. We provide support to people who have experienced a first episode of psychosis.
And I'm Kaylee. Hi, everyone. I am an occupational therapist, and I also work with Leanne at CMHA on the First Step team.
We're going to be introducing also another speaker who's joining us today, Sam and Stacy. Would you like to say a couple words, Sam or Stacy?
Want me to start?
Yeah.
So I'm Stacy. I'm the early psychosis intervention nurse at CMHA in Parry Sound. And this is Sam. She is one of my amazing clients. You want to introduce yourself?
Yeah, I'm Sam. I'm 21 years old. I've been in the program since high school.
Excellent.
And then diagnosed in 2020.
Excellent. Thank you so much, Stacey and Sam. Over to you, Leanne.
Okay, so we'll get started with the presentation. All right. So if we can just move on to the next slide. I forgot I don't have a. Okay, perfect. So welcome. Thank you so much for joining us today. Our aim for today is to give you a brief overview of what psychosis is and what the causes of psychosis are. And as well to talk a little bit about cannabis and youth and the link between cannabis, youth, and psychosis. So I'm going to be covering those parts of the presentation, and then Kaylee will move into talking about supports that can be helpful to students that are experiencing psychosis, as well as what is early intervention, early psychosis intervention, and why is it important. And then we're going to finish off today, and Sam is graciously going to share a little bit of her own story of her journey. We're going to try and wrap up around maybe 11:45, 10 to 11, to give you time for questions afterwards. So we can move on. Okay, so we're going to start today with a really short clip with some folks talking about their experience with psychosis.
Sorry, folks, give me one moment while I try to get this video up. Here we go. Can folks let me know in the chat if they can hear?
We can't hear.
Okay. Let me just make sure that we have video and sound.
Oh, others are saying they can hear, however. I see that in the chat. So maybe it's mine.
Okay. We're going to keep going in that case.
Sure. Oh no, people can't hear.
Sorry about that, folks. I will try to fix that, but I think we might have to move on. I'm sorry about that.
Yeah, no, that's okay. That's all right. I think we can make do without the video anyway, and especially as Sam is going to be sharing a little bit about her story. I think that will give you a little bit more of that personal experience. So we'll move on to the next slide.
And the link will be available on the slides. So
yeah, absolutely. Yeah. Okay, so what is psychosis? Psychosis is actually a medical condition that involves chemical changes in the brain, in the brain's messaging system. So really, when people experience psychosis, the changes in the brain affect the way that their brain sort of interprets and experiences information coming in about the world around them, the way it interprets it, and also their ability to sort of process that and communicate with the world around them. So what ends up happening is people that are experiencing psychosis end up having a distorted sense of reality. And this can come on suddenly or gradual, which I'll explain a little bit further. So there's three categories of symptoms: positive symptoms and negative symptoms and cognitive symptoms. By saying positive and negative, we don't mean that they're good and bad. Positive refers, if you think of it like a plus sign or an addition sign, it means that positive symptoms are something that have been added to the person's typical experience in life that wouldn't normally be there, and negative symptoms are things that are missing. So an example of a positive symptom would be a hallucination. So this is where people experience changes to their five senses. So this could be sight, smell, hearing, touch. And so they may start to hear things that other people aren't hearing. This is what we call an auditory hallucination. So people, as an example, they may hear voices of people that are there. Often it sounds like maybe there's somebody kind of right there in the background with them, whispering in their ear. It could come out as they might hear it as whispers. They might hear it as full-on conversation between two different people. They might hear it as kind of gibberish or like a loud crowd in the background. It can really vary. And voices can be both have good things to say and very negative things to say. So people experience different things. Sometimes they may be commenting on what the person is doing. Sometimes they might just be saying the person's name. And sometimes auditory hallucinations can also just be sounds as well, hearing sounds in the environment that other people don't hear. So then that's auditory hallucinations are the most common. People can also experience visual hallucinations, so seeing things in their environment that other people don't see, as well as changes in taste. Sometimes people are worried that things might be poison because their perception of taste changes, or even changes in touch. So feeling like something is happening to their body, something has changed. And the next type of symptom is delusions. And so these are false beliefs about the world around us. And delusions can be quite fixed and very, very real for the person. So are hallucinations. When they're experiencing them, they're very, very real for the person. So when we think about the brain, when these changes are happening and all these, the information that's coming in, they're experiencing things that other people aren't. The brain sometimes starts to interpret things in certain ways. So a delusion could be, often people may feel worried that people are out to get them. This is called a paranoid thought or paranoid delusion. So this is very common with psychosis, the worry that people are being watched, that maybe they're being monitored on their phone, that people around them are always watching or talking about them. Some people have what we call grandiose delusions, where they may develop beliefs that they've got something very important in the world that they have to do. Maybe it's like, I need to save people from something bad happening, or that they're going to be the next CEO of Google, or accomplish something really extraordinary. There are other types of delusions that I won't go into, but I think what you would find is that when you're talking to somebody that's in a state of psychosis, it can be difficult to like at times sort of rationalize or against the around the delusion. It feels very weird, or sorry, it feels very real. And also disorganized thoughts and speech. So sometimes people, when they're experiencing psychosis, their thoughts may be sped up, very disorganized, and this may even come out in the way that they're talking. Negative symptoms, once again, things that are missing. So this could be things like a person's motivation and energy, a person's ability to sort of feel pleasure with things. Sometimes people will present as being very sort of flat in their emotions or their facial expressions. And even in their rate of speech, we may see a person's like speech or their response time sort of slowed down. And cognitive symptoms, this is a really important one for those that are in school. So with all these changes in the brain, it makes sense that people may experience changes in their cognition as well. So it's very common for people to struggle with attention and concentration, memory, planning, and organization when they're experiencing psychosis and even in the recovery phase. So with a psychotic disorder, so what I mean by that is when somebody has an underlying mental illness that causes them to experience psychosis, such as schizophrenia, there tends to be a very gradual onset. And the first phase is what we call the prodrome phase. And in this phase, changes are starting to happen for the person. And so for people on sort of around the person, they may start to notice things like specific changes in their behaviors, like withdrawing from school or work, withdrawing from family or friends or activities that they used to enjoy doing. maybe trouble sort of keeping on task with the things that they usually would do, cleaning their room, taking care of themselves, their hygiene. This is often mistaken at this stage in life as like, maybe they're using drugs, maybe they're just being, you know, as psychosis can often start in adolescence. It gets blamed on adolescent behavior. And then eventually, though, it can develop into a full-blown acute psychosis where all those symptoms that I mentioned before could be presenting. And then we have the recovery phase, which if you look at the little chart there, it's not a straight drop off or a straight line. It kind of goes up and down. And in this phase, where a person is usually getting some sort of treatment, the symptoms may start to lessen or disappear entirely, and people are starting to cope better day to day, usually with medication and treatment. Like the those positive symptoms, the hallucinations and delusions, are the first ones to sort of improve first, and then the cognitive symptoms and the negative symptoms are the ones, they take a little bit longer. We may also see a return of symptoms at some point. And if a person is getting support, hopefully we can also help them catch that early on, so it doesn't have as maybe as big an impact as their initial episode did for them. Next slide. Okay, so psychosis is actually fairly common. So it can affect 3 in every 100 people, which makes it as common as type 2 diabetes. It usually happens between the ages of 16 and 30 years old. That's the most common time period, although it can happen outside of that. Our program supports people ages 14 to 35. And it's usually as common in males and females. Although interestingly enough, for females, it usually happens a little bit later in life. And I've been told in the past that there may be a protective factor with estrogen for females that around psychosis. All right, next slide. Early psychosis intervention programs have been created to try and help intervene as quickly as possible for people to get them the treatment they need. So the longer a person experiences psychosis, the more without treatment, the more likely they're going to experience disruptions in their schooling, their work, and the relationships in life. They're more likely, their psychosis may more likely end in a potential hospitalization, suicide, unfortunately, maybe substance use as people are trying to cope with what's going on around them, even involvement with the justice system, and just disability. And what we mean by that, sort of longer term impairment in their ability to sort of do the things like school and work and take care of themselves. So the causes of psychosis, we can go to the next slide. Yeah. So there are biological sources of vulnerability. So there's not one main cause of psychosis, but more rather like a bunch of different factors that can increase your risk of psychosis. The first one is genetics. So it is shown that people that have psychosis in their family are at a higher risk of developing psychosis, just kind of like if you had heart disease or diabetes in your family, you're at a higher risk of developing that. However, more than 60% of clients do not have a family history. So there are other things at play there. There is found to be biochemical abnormalities. So dopamine is a very significant chemical involved in psychosis. And when there are higher levels, when a person is experiencing psychosis, there seems to be higher levels of dopamine in their system. As well, people that have experienced psychosis or are experiencing it seem to have abnormal brain structure. So larger lateral ventricles, abnormalities in the pattern of blood flow and electrical activity within their brain as well. Important to note though, despite these changes in the brain, we can't use brain scans or MRIs to diagnose at this point in time. Also, environmental influences. So research has shown that certain factors that people are exposed to in their lifetime can actually increase their risk of developing psychosis. So viruses or prenatal or antenatal difficulties for the mother has been shown to increase the risk of psychosis for that child later in life. Immigration, trauma, and also urban living. So interestingly enough, people that grow up in the country in rural areas are at a lower risk of developing psychosis. And finally, street drug use as well. Marijuana in particular has been associated with an increased risk of schizophrenia, which I will explain more about in just a minute. Next slide. So this just sort of shows how this kind of, all these factors at play, the more factors we have, the higher risk of developing psychosis we have. Sometimes we talk about people having just a very sensitive brain. Some people are, maybe because of genetic or biological vulnerabilities, they're more predisposed to developing psychosis. And then you add in all these things on top, and it increases the risk. So when you think about students and all the things that they may be experiencing, there's a genetic vulnerability, and then physical stress, late nights, maybe poor diet, lack of routine, drug use, and so on. Environmental stress, so they may be in new situations in school, financial difficulties, school demands, sharing accommodations, lots of stress when we enter into post-secondary education, emotional stress, maybe peer pressure, relationship difficulties, conflicting cultural values and beliefs, bullying, discrimination, these types of things also add to that bucket, and then potentially increased drug use as well. Next slide. Yes. Okay, so I'm going to talk a little bit about cannabis. So cannabis use has been linked to psychosis. So a lot of folks that come into our program, when they're referred, have experienced what we call a cannabis-induced psychosis. So people can, some people that are very susceptible to psychosis, when they use cannabis, they may experience an episode of psychosis. This is not the same thing as a bad trip from drug use. This is an actual episode of psychosis that's short-term and will resolve when the drug use is gone. However, those that are predisposed to developing a mental illness, even once the drug use stops and the drug is out of their body, psychosis sometimes can persist. So what we know is that the earlier the use starts for youth, and the heavier use, the greater the risk for psychosis. So the little picture here shows that daily users of high potency cannabis are 5 times more likely to develop psychosis than the general population of non-users. And when someone's age at first cannabis use is under 15 years old, their risk of developing psychosis will be 1.6 times the greater. And then daily users of cannabis with the potency of THC, which I'll talk about in a minute, being less than 10%, they're still more than 2 times more likely to develop psychosis as opposed to non-users. So we'll go on to the next slide and I'll explain a little bit more of that. What does that mean, potency of THC? Some of you may know, some may not. So the next slide. Okay, just want to make a note that it's not just cannabis use, also drugs such as methamphetamine and cocaine. All these drugs increase dopamine levels in the brain, and they also can induce psychotic episodes. We're focusing specifically on cannabis today because it is probably the most commonly used drug and on like an ongoing, like on a chronic kind of daily use that we see, and probably the most common drug that we see inducing psychosis in our program. So next slide. Okay. So really quickly, just the difference between THC and CBD. THC is the chemical in cannabis that makes you high. It's also the chemical that increases dopamine. And CBD can have lots of health benefits. It's been found to reduce anxiety, help with pain management. But usually the cannabis that people are using tends to be quite high in THC these days and very low in CBD. So what we know with cannabis use with youth, they are more likely to have difficulty with attention, overall IQ, memory, processing speed, and motor skills. So next slide. Just really quickly. So what I mentioned before is that you can see here on the slide, or on the little yellow arrow, that those that have never used cannabis have never used are at a low risk of psychosis. Those that have smoked less than once per week, a little bit higher. Those that use on the weekends, a little bit higher, and those that use every day. And it says smoke, but this is all cannabis use, right? You can ingest it, you can use it in many different forms. It increases. And then over here, it talks about a conversion to schizophrenia after a substance-induced psychosis. So those that may have a genetic vulnerability to developing schizophrenia or a schizophrenia spectrum disorder, when using cannabis, they're at a risk of this then converting afterwards to schizophrenia. So the psychosis continues to persist, and it requires ongoing treatment to help keep the psychotic symptoms. And so I'm going to stop there and let, actually, so there's one more slide, just a couple of harm reduction strategies if you are working with youth. So encouraging things like, we try to encourage people not to use cannabis every day. So cannabis THC gets stored in your fat cells and takes about 3 days to leave your system. So when people use every single day, THC builds up in your body. As well, using cannabis with lower THC levels, we really encourage people, if they can, to get below 10% of THC if they're going to continue to use. They're still at a risk of psychosis, but the risk is decreased. Yeah, so from there, I'm going to just share a couple. You can access these if you want some more information about cannabis and psychosis. There are some links on here to some really great websites, and you can look at that when you access the slides. I'm just going to skip over this actually, just to let Kaylee start on her bit.
Thanks, Leanne. Yeah, so as I mentioned before, I'm an occupational therapist with the team. So a big part of my role is supporting participants of our program who are in post-secondary. So college or university, they're applying and starting out, or continuing and getting back to school after they've had an episode. So I've put some info here, and I'll go through it just around some of the things I've learned that are most helpful in supporting students who've experienced psychosis. So next slide. So if you're working with a student who you're wondering if maybe they are experiencing psychosis, I've put some information here around how you might collect some initial information if you're trying to figure out what next steps to take. So psychosis rarely presents in neat parcels, meaning it's not necessarily going to look exactly like Leanne's slides, where it's kind of laid out in a certain way and you're able to say yes, this is definitely psychosis. And students might not be comfortable volunteering information. And so the biggest thing is just observing them. If it's a student that you're familiar with and you know how they would typically present, it's just about observing how they're presenting now, and avoiding some of that textbook or medical language, right? So probably avoiding asking, are you having hallucinations? but rather asking open-ended and non-leading questions, just trying to gather general information around what they're experiencing. I put some examples of questions that are sometimes helpful to ask or that sometimes we use during assessment. Like, have you felt that something odd might be going on that you cannot explain? So allowing the person to share some of their experience that feels very real to them. And then also keeping in mind cultural context when you're gathering this information, that maybe someone's spiritual views might be different from yours. And so also keeping that in mind, that maybe somebody already has certain views that may be considered delusional to you, but they're actually just their typical everyday views. Next slide. So let's say you go through some of that questioning, you're finding that maybe the student is not presenting as they typically would. You have some suspicions around psychosis. Some of the responses maybe seemed a bit bizarre. Here are some of the steps that you can take. So obviously taking them seriously. Maybe you've had friends raise concerns, so taking those seriously. And so checking out the local epi service provider. So we're going to talk a little bit later about what our teams do, but there are teams all over the province, and anyone can refer. So making a connection with your local team and referring them. You can connect with the student's family doctor, who can also refer. And there's a whole bunch of other resources on our website, which I've linked here and will also link later. And then these additional websites here as well. If the student is not open to that, if they're not wanting help, if their insight is not fully there and they're not wanting to talk about it, it's also just about staying available. So keeping your door open. They're probably really stressed and scared from what they're experiencing. So just continuing to be approachable and there, checking in with them, seeing what their needs are, if they're comfortable providing some of the resources to their family or friends. And then obviously following your school's emergency protocol if there are threats to self or others. So experiencing psychosis can really impact like all parts of a student's life on campus. It can make students feel uncomfortable around other people. So it might lead them to avoid class or other social events. It might lead them to isolate more in their room if they live in residence, or stop talking to their roommates. It can lead to difficulty concentrating in class and doing assigned readings, or even just keeping track of due dates, like even knowing when a due date is, or not understanding the importance of due dates anymore. It can decrease self-esteem. You might see changes in mood. So a student might have trouble regulating their mood in groups or in class. Or maybe their facial expression will change and look different than it did before. And so that might also change how they're interacting with their friends and their peers. Their hygiene might decrease. They might stop doing things that they typically enjoy on campus, some of the extracurriculars or clubs they were involved in before. Their sleep might change. And just generally all of those aspects of their daily life will slowly start to be impacted. You can go to the next slide. So in supporting students who might be returning to school after an episode of psychosis, this can be really scary for students for a lot of different reasons, especially if they're returning to a program that they were in before. I support a lot of students who ask about like, what should I tell my peers? What should I tell people that when I'm coming back? How can I explain this? Do I have to explain this? And so just being really understanding of the stigma and how scary this experience can be. Remembering that psychosis is a brain disorder. And so there are going to be ongoing brain recovery that's happening over a long period of time. And that medications, which are really important for treatment, can also have side effects that the student might be experiencing while their doses are being changed and they're still sorting out what their treatment is going to look like. And so their brain healing and medication side effects can also impact them when they're getting back to school initially. So you'll see changes or difficulties with concentration and thinking, and academic accommodations are almost always recommended. You can go to the next slide. So I'm sorry this font is small. I tried to provide some examples of specific functional impacts that I see a lot, and then the accommodations that I find are helpful, that students find helpful. So sedation is a really common side effect with medications, especially students like waking up really groggy in the morning, having trouble getting out of bed in the morning. So we'll often request an accommodation for tests and exams to happen later on, like an 8 a.m. exam would just not be possible for a lot of our folks, and support to adjust their timetable. So maybe like an early morning class might need to be adjusted. Difficulties with concentration and memory, accommodations that are helpful for that might be extra time on tests and exams, the ability to write an exam in a private room or a test center if you have one, note-taking support, or I'm seeing a lot more of that recording software that a lot of schools are offering, and students are finding that especially helpful. Challenges with organization and planning. So needing to spend a lot of time making sure that they know when their due dates are, and they're planning, chunking all of their tasks in advance of the due dates. So extension on assignments can be really helpful. And the general lower stamina, just that comes from recovering. And then having extra appointments that they're attending all the time. Sometimes students do need to drop down to a part-time course load. And so having extra support, even just like normalizing that's totally okay to do, can be really helpful. We often support students to fill out the OSAP disability verification form. So just providing education that, you can take part-time classes and still have full-time student status for OSAP. That can be really helpful. Adaptive technology, and I've included some other resources that I find are typically helpful. You can go to the next slide. So we've talked about this already a little bit, but you can go to the next slide. So what is early psychosis intervention? EPI programs are funded by the Ministry of Health and Long-Term Care. There are over 40 across the province. And the idea is providing intervention early on. So like Leanne said, the longer an episode of psychosis goes untreated, the greater the functional impact. And so we want to be accessible, and we want to provide support as soon as possible. So anyone can refer. You can self-refer, a family member can refer someone, or a doctor can refer. And we typically try to engage with someone as soon as we can. We try and eliminate hospital admissions as much as we can, get people back to the activities that they were doing before as fast as possible. And so if you go to the next slide, you'll see a map with our distribution across the province. This map is available, it's interactive on the website that's linked there. And so if you're unsure, for example, if you're working with a student who lives in a different city than the city that their school is in, you can visit this website, type in the city, and it will show you the program and the contact information for that program. And I will pass it over to Sam.
Hey, everybody. Sam just wants me to say a little bit. She's just experiencing some positive symptoms right now. This is the first time she's been able to talk about her story since being diagnosed. So she just kind of wanted me to say a little bit, if that's okay. Okay. just to a little bit, when Sam started in high school with anxiety, that's what they thought was happening. And she actually tried to be accommodated and was not eligible for any assistance because she was taking academic courses, which is pretty sad. And then she finished high school in 2019, wanting to go be a teacher. Do you want to say it?
Yeah, and from there, I did get into Nipissing University for teaching, and that's when my psychosis started to affect me a little bit more. And it got to the point where I was experiencing like a lot of high stress symptoms and like not being able to do my classes. I would actually open my laptop and I couldn't log into anything because I was just too stressed and too many symptoms were going on at the same time, and I didn't know how to deal with it properly. So from there, I actually dropped out of school. I was in school for a full term, but I didn't go to any of the classes or do any of the work.
Isolated.
Yes, I definitely isolated. From there, I dropped out in, it would have been the end of 2020 or beginning.
Because you were diagnosed in 2021?
Yes. And then after I dropped out, I realized something was wrong and came to CMHA and got diagnosed in 2021.
So she still sometimes does experience a lot of the positive symptoms, but she's on medication daily. You did well, just breathe. And she's compliant with her medications, which has helped her be stable.
Yeah.
But she has changed her views on university and college just right now because she felt that there was not enough mental health supports that she could access because she wasn't aware of them. So yeah,
I think a big thing with school was it was at the beginning of COVID and everyone was still trying to figure everything out. And I wasn't aware of what mental health help I could get through the school system. I don't even believe I got any emails about any possible help, which I feel like if the schools could put in a system where they can email like within the first week new students, just telling them what would be available and like having it right there so that everyone can see it. And if you skim through it, you can skim through it and get the information nice and easy.
so she was also scared to reach out as well because of having that kind of the delusional thought that everybody was out for her and, out to get her and stuff. So that was pretty difficult with her having that fear as well of not being able to reach out to people. So yeah, just kind of talking and saying that schools would be a lot better if there was more peer support that with lived experience to help college and university students, especially first years who might be 17, 18 now going. So, but she's quite stable. She's got 2 jobs. One of them was her one that she really wanted. And she's doing really well now, minus the very stressful times that she has.
I don't know if there's anything else that
You don't know what they can ask you.
any questions I'm open to answering.
Awesome. Thanks so much, Stacey and Sam. Thanks so much, Sam, for sharing your story. That was really special. And I'm sure if anybody has any questions for you, they'll put them in the Q&A and we can hopefully get to those at the end. It's
Thank
just
you.
one more slide for us to get through today.
This is just our last slide, just remembering how common psychosis is. Don't dismiss change as just adjustment to post-secondary school or substance misuse. So Kaylee was saying, really watch and observe. And also really pay attention to concerns that are coming in from friends, dons, faculty, that kind of thing. Most importantly, know that psychosis is treatable and that, people, when they get the support and treatment, they can really go on and have successful and very, lives and manage very well. And that culturally competent care is very important. And the last point says your responsibility does not end with referral. So obviously your ongoing support and reintegration into school and campus living is absolutely paramount. And I want to say thank you, Sam, as well, for your suggestions and for speaking today. I think that was very, very brave of you. And your suggestions are very helpful. So should we turn it over for some questions then?
Yes, fantastic. Let's definitely do that. So we have lots of questions in the Q&A section, so that's great. And just want to comment, there's lots of thanks Sam's being mentioned in the chat. People are very, very impressed with you, Sam. So thank you so much for sharing your story. People are very happy.
Thank you
that
very much. She did want to mention though before that prior to wasn't a smoker, wasn't a drinker, did not use cannabis. There was none of that. So there was none of those like, yeah, none of those kind of extras. Yeah.
Yeah, so it can definitely happen without those things as well. Yeah. Thanks so much for that. All right, so let's start getting into some of these questions. So we have lots and lots of questions. We're probably not going to get to all of them, but I'll start from the beginning here. So the first question is, psychosis is higher risk for people if they already are predisposed to psychosis or have family history with cannabis? This seems like maybe a clarification question.
It's not really that as there isn't any research that we're aware of at this point that shows that if your family uses cannabis, that you're at a higher risk. It's that if your family has experienced psychosis. Lots of people use cannabis and don't develop psychosis. It's kind of like, one of our psychiatrists kind of refers to it as like some people can eat peanut butter and some people are allergic to it. So when we think of it that way, some people's brains are just really sensitive and predisposed to developing psychosis, and that use of cannabis really can increase that risk.
Thanks for that, Leanne. The next question we have here is someone asking to kindly clarify the 3 in 100 figure. Their understanding was that it was 1 in 100.
I'll have to check. That slide wasn't created by us, so I'll check. Kaylee, do you have any, are you familiar with the 3 in 100 as opposed to 1 in 100? 1 in 100 is actually for schizophrenia specifically. So I think that's where, so people can have psychosis and not have a diagnosis of schizophrenia. So I think that's where the difference is. But yes, the statistic is that 1 in 100 people will have a diagnosis of schizophrenia.
Yeah, the 3 in 100 is and like people experiencing a psychotic experience of any kind. Great.
And it looks like Margot in the chat has said that ChemH says it's 3 in 100. So that makes sense. All right. So the next question we have from an anonymous person is, I wonder if the speaker could speak to the intersectionality between psychosis and other mental disabilities.
Sure. Many people that develop psychosis will also have other types of mental health diagnoses as well. So it's very common for people to experience anxiety and depression. As well, some people may experience both psychosis and a mood disorder. So potentially like ongoing depression or symptoms of mania as well, which is characteristic in bipolar. So there are a number of mental health diagnoses that you can actually, psychosis can be a part of it. You can experience depression with psychosis. Bipolar 1 is also, so there's 2 types of bipolar 1 and bipolar 2. When people experience bipolar 1, they've experienced psychosis in a manic episode. Bipolar 2 does not include psychosis. Hopefully that's a broad enough explanation.
Yeah, I think that was helpful. Thank you. All right, our next question here is it possible to be in active psychosis without experiencing the hallucinations in specific, but other symptoms are present, primarily the delusions? So I believe this question was asked in the chat, and I believe there was an answer from Stacy and Sam saying that yes, you can experience psychosis without hallucinations. Is that correct?
Yeah, absolutely. And so there's like a wide range. Sorry, Stacy and Sam, you answered that. Did you want to speak to it? Okay. Okay. Yeah, there's a wide range of presentations of psychosis and a wide range of diagnoses as well that kind of fit within that psychotic spectrum disorder. So for example, there's something called delusional disorder where somebody's more likely to experience delusions, fixed delusions that kind of persist, and maybe not so much the hallucinations or some of the more the negative symptoms or the cognitive pieces.
Mhm. Great. We have a thank you for clarifying, so that's great. So the next question, we have so many questions here today. People have lots of questions. Can using antipsychotic medication to treat depression and anxiety increase likelihood of developing psychosis?
Can treating can using antipsychotic medication lead to psychosis?
Yes, to treat depression and anxiety.
Not that I'm aware of. Anyone else have that? When you think about it, I mean, antipsychotic medication is it should be protective around psychosis. I'm not aware of any research that says that it would lead to psychosis. Yeah.
Okay, that's helpful. Thank you very much.
Yeah.
All right, so we answered that one. Are there similar EPI supports outside of Ontario?
Yes, there are. Sorry, I'm answering. Kaylee, do you want to?
I was just going to say it depends on the province, but yes, there are different iterations in different provinces. I know Quebec has an excellent network and BC as well. So it would just be about exploring the specific resources in that province.
Excellent. All right. Someone here has asked if it's possible to send links to resources mentioned regarding cannabis use. So yes, I'll be collecting all of the resources and links that were in the presentation, and I'll be making sure those are available with the recording today. We have a question here for Sam. Sam, are you ready for a question? All right. Was it just medication that helped you heal, or other therapies or supports or interventions?
I definitely have a lot of support from friends. And I've been seeing Stacy for a while, so that's definitely helped. We've worked on like coping skills and like how to keep myself a little less out of my head.
But medication.
Yeah, but medications have definitely helped a lot.
That's awesome. Great to hear that. Thanks, Sam. We have another question here. I'm curious about how we would differentiate between symptoms of anxiety and depression in post-secondary students compared to psychosis. They seem that they overlap quite a bit.
Sorry. They do overlap, and so it can be tricky to sometimes, especially with really intense anxiety as well, or with the withdrawal that someone may experience from depression. It can be difficult to differentiate. I agree. So lots of observation. I think really paying attention to what the person is saying around their anxiety as well. Like, how plausible is it that are they experiencing, like, what is this like fear around people talking about them? Are they actually hearing people everywhere they go talk about them? Because that's not likely what's happening, right? So trying to ask some more questions, like really curious questions, just about like, what are they experiencing? Tell me more about that. How often does this happen for you? Where are you experiencing it? How do you know this is happening, right? Like maybe even just check in about some of that stuff. Sometimes when we get referrals to our program, like it's not even clear right off the hop for us. Like we really have to do a deep dive into seeing what the person is experiencing to really figure out, is this psychosis? Is this something else? Yeah.
And I would just add to that, Leanne, that we look for if the changes in behavior would be considered bizarre for that person. So if what they're saying or feeling is bizarre within their context, that's usually the sign or the signal for us.
That's really helpful. Thanks, Kaylee and Leanne. Okay, another question we have here. Are medications typically taken for life, or do people get off them in remission? Great question.
Yeah, so also guys, feel free to hop in. I don't have to be the one. I'm the type that will like the silence, I'll jump in right away. So I don't mean to be taking over, but Yeah, no, it is possible that people won't have to take medication for life. Some people will find that they need to. It kind of depends on the cause of the psychosis and, you know, different factors in their life. But we often in first episode psychosis, like our programs last, we can support people for up to 3 years. And part of the reason why it's so long is really to like, first of all, really observe people for a long time before giving a diagnosis, give them an opportunity to like maybe slowly come off their medication and see if symptoms come back for them so that we can be there to try and catch it and prevent like a full-blown psychosis. Some people will find that they need to take ongoing medication to prevent psychosis symptoms from coming back.
All right. We have time for one more question and then we'll wrap up today. So the last question is an easy one, I think. Are people with schizophrenia eligible to access EPI?
Yes, absolutely. So there is some, I should clarify, with early psychosis intervention, it really is about supporting people that are experiencing their first episode psychosis. So when a referral comes into our program, we're looking to see how long have they already had a diagnosis? Have they been on antipsychotic medication for over 6 months to a year? Have they been experiencing psychosis for like 5 years now? That kind of thing. If the psychosis and this is not their first episode, they may be more appropriate for a service that's like maybe has similar supports, but it's not a first episode psychosis. So sort of long-term mental health support that can look different in different communities. But certainly a lot of times when people come to our program, they don't have a diagnosis of schizophrenia right away, right? Because it takes time to diagnose that and make sure that that's actually what's going on.
And when in doubt, refer, and the EPI program can direct them into the right program if it's not a good fit.
And just quickly to answer the question about medications as well, I find historically with clients who have come in with cannabis-induced psychosis, usually aren't on medication, but if they have come in and they've had like depression and anxiety and all these other things before being diagnosed, they're usually on medication for quite some time, if not for good.
That's really helpful. Thanks so much. All right. So with that, we're at 10:59. So we'll close up for today. I'd like to say thank you so very much to Leanne, Kaylee, Stacy, and Sam. Your insights today have been very, very helpful and very instructive, informative for our audience today. Thank you as well to our audience. Thanks for joining us today. We really appreciate you having all here to join us today. And again, just another reminder to please fill out the survey that will pop up on your screens when you close this webinar today. Thank you so much, everyone. And I believe Leanne wanted to provide something as well.
Yeah, I just in the chat, if you didn't see it, there's lots of stuff coming in there, but I did put my email address. So if you have a question that didn't get answered, please feel free to email me and let me know.
Fantastic. Thank you so much, everyone, and we'll see you next time. Take care.
Thanks, everyone. Thanks, Sam and Stacey as well.
Yeah.
Bye-bye.